What I'm going to present is for some out-of-the-box thinking. From other people are a provocation, and for other people is an insult. And please, for the ones that think that is an insult, don't see it in that way. And just open your eyes, open your ears, and just watch, okay? I'm mainly a prosthodontist, and restoring implants is difficult. What you're gonna see is 80 years of, it started 8 years, and mainly the last 6 years, it became a routine. So today, I cannot conceive placing an implant without connective tissue graft, okay? So everything that you're gonna see, every implant that I place in the mouth is with connective tissue graft, okay? And I treat patients that are dentists, and they are looking for a restoration that looks like a tooth. And dentistry is about, implant dentistry is about controlling the volumes and the scalloping of the tissue. It's a three-dimensional issue. So if you have the tissue, then the rest is piece of cake, you have a nice case. So let's start from the criteria. This is a basic lecture, so everybody understands, and look at what we need and what we strive for when we have a single anterior tooth with a high smile line and you have a challenge. An implant is always a challenge. So we'll go to a criteria, have an idea about what is simple, what is complex, what can be done by yourself, or something that you have to refer because maybe it's too difficult for you. You need to understand that in dentistry, you provide the treatment based on your knowledge, your ability, your dexterity, and your feelings. There are a lot of things in the literature that there is no answer. I'm looking into the research, and we do a lot of things with no research at all, even though it seems like what we do is a research-based treatment, and it's not true. So I want to show you these two pictures, okay? One in the left, one in the right. Which one would you like to restore? Well, I would like to restore the one on the left. Why? Because the tissue is coronal to the tissue that I want to copy. And basically, we look at three things. The problem is, surgically, I want to improve the tissue vertically, coronally, crestally, and then in the other side, I have the tissue leveled. Yet I'm getting old because I see my white hair here, so I should be looking at you. So basically, we'll look at three things. I will be short, but interproximal bone is maybe the most important issue. If you have interproximal bone, if you have bone to the adjacent teeth, then you are in a better way. You will improve. You will be able to do something in that case. Then we look at the volume, the pharyngeal margin, where it's located compared to the one that you want to copy. And you want to have that margin around your healing abutment as coronal as possible. And then the volume located incisally or coronally to the one that you want to copy. If you end up surgically, like on the left, you will have 100% of chances to control how much pressure you want to create on that tissue, and you will be able to control the final result. The problem of getting that tissue crestally is the healing abutment. And I came up a long time ago. This will come out in Germany in September. And those are healing abutments that allow you to maximize your soft tissue grafting. Because there is something that you need to think in terms of surgery is the sealing of your flap. the sealing effect of your flaps are crucial in order to get different type of results. So when we look at delayed implant placement is the way that you do the surgery. We don't do any more vertical releasing incision. This is the dinosaur era. We don't expose the bone if the bone is already there. So the less you expose the bone to the oxygen, the less resorption you will get. So there are many things. It's a comprehensive approach about what we do. The incisions, the flap designs. And for me, the healing abutment was the one that always was a problem for me, because it was taking too much space, too much volume for me to really be able to hike that tissue to a different level. Having a healing abutment that is like a screw, 1.8 millimeters in diameter, then I can place the thickest and densest tissue that I can harvest and be able to close my flap. Because the issue is not placing my tissue on the buccal aspect like everybody does. The issue here is try to graft crestally, mesiodistal and buccolingually, having the thicker tissue on that crest and be able still to close my flap. So manipulation, the grafting is crucial in order to get a different result. So I never take a 3 millimeter healing abutment high, because this is where I don't have enough vision surgically to advance my flap. I don't use either diameters that have the same diameter than your implant, because let's face it, all the healing abutments that are into the market are more thinking about the prosthetic final result rather than helping the surgeon to close the flap. So the trick is to create as much tissue coronally, let it heal, and then push it. This is the trick. It's like an elevator. You want to increase it, to then push it, and I want to have it as denser as possible. I learned that if the papilla are in the right place, don't touch the papilla. And actually, I'm telling you now totally the opposite. If you want to improve the papilla, involve it in your flap, because it will increase, you will not only increase the height, but the most important, the buccolingual volume. So it's a totally different out-of-the-box thinking. It's a totally different way of looking at implant dentistry. And for me, it's a paradigm shift. I think less and less in bone, and I think more and more in tissue. So I wrote a book. It took me 8 years to get where I wanted, and hopefully in August it will come out. This is a totally different approach. It's basically, for me, the buccal plate is not important. You say, what are you talking about? Well, when I look at the case and I have a buccal plate loss, I look more to the palatal bone than to the buccal bone. So if in my scanner, I see that I can place my bone in that palatal bone that is being left, I don't do ridge preservation or socket preservation. Why? Because I have to wait between 6 to 8 months before I get in. But what I think, and I couldn't agree with anybody that has been before me, the sealing of the tissue is really important. And I agree with Eric that the thicker the tissue on the crest, the more you seal that, and you are in the position of doing it, the more you graft the day of destruction, the better result you will see. But the most important, and that nobody says, is that you will have a thicker tissue in the crest that will support the tension in a better way. If you think about it and extract the tooth and don't do anything, that tissue, that hole, that socket will be closed by secondary tension. But within 3 months, the quality of that tissue is really poor. The issue now is that I compensate the volume that has been lost with a healing abutment that allows me to recreate the connective tissue around the implant. We have two versions. We have a 1.1, 1.8, and this version allows you to combine an immediate aesthetics if you ever have an initial stability of your implant. Okay? So let me go into it and show you and discuss what is coming out and how we have been working. We have from 8 to 6 years results. So you just watch, look, digest, and then decide. So those healing abutments are only 5 in height and 7 in height, because it depends where you want the implant to be placed. Sometimes you don't want to bone graft coronally, and there is something that we have to face. I only put 5 patients, and I will do bone surgery on 5 patients, and if it happens to me, it happens to you. From bone graft, among the 5 patients that I see, because we all look the same, but we are totally different. We have a gene information. Some of us smoke, others take antibiotics. From those 5 surgeries that I'm going to do bone-wise, I will have 5 totally different responses from my surgery, doing the same technique. Doing connective tissue, I will have a more predictable response in those 5 patients. Why? Because it's their own tissue. Okay? So I will show you a little video to see how it's done. Crestal incision, normal crestal incision, partial thickness flap. The implant is already being placed, and we're going to put the connective tissue coming from tuberosity. Why? Because we know it's different. And why is that different? Because it has high concentration of collagen. Palate is not good enough. And you take it from the palate, take it from the epithelium. I agree totally with Zucchelli. Don't take it from the underneath. It doesn't give you anything. It resorbs, it's not stable. What I want is a tissue that what you put is what you get. And this is, obviously, the epithelium has been taken out. And the quantity of tissue you get from tuberosity is 10 times more than the palate. So this is how we do it, just a cross incision, vertically, and you go on top over the healing abutment. The healing abutment is, in a sense, the one that is going to stabilize the connective tissue, and you have to tailor the tissue based on the defect you have. Okay, so you just go in, plumb. Any dentist in the world can close this flap. We always suture the connective tissue in 2 layers. We fixed, because in essence, in surgery, the most important is to have stability of what we do, bone graft, membrane with tags, etc. So you stabilize the connective tissue, and then you close your flap on top of it. How did they came to this? It's not by a matter of chance. It's by a matter of facing my problems. And my problems were, I want to increase the volume because I know that the more volume I put, the better result I have long term. And besides that, it's a living tissue, and that tissue creeps. This is something that I don't have with bone, or tissue coming from palate as much. So we looked at concave. Concave doesn't work because the tissue glides. So I said, well, let's put some holes. But it's too difficult. It's appealing for the dentist, but doesn't work. And then we said, well, let's take the diameter off, and this is the one that really works. And the last one is, I hate having patients that come to my office with a debonded tooth during the process of delivering my treatment. So some pages of the book is like more a narrative book than a textbook. So the research is in front of each topic, what we know. To tell you the truth, we don't know too much. And the healing abutment, the tissue glides. So I thought at the beginning, well, let's have a wider top so it protects the soft tissue. But only the wider is at the top, the more difficult is to have a primary closure, a lot of tension, not easy, doesn't work. If you look at this one, you say, wow, this one, you can suture the tissue around. Doesn't work. It's way too complex. You need to know how to suture with 6, 7 zeros. And it looks nice, but it doesn't really work. So basically, it's about a soft tissue concept. It's about trying to reconstruct around the implants with soft tissue grafting, coming from a totally different donor side, having something that is maintained not by adhesion, but only by the structure, the morphomolecular structure of the tissue, the density of the tissue. People ask me, how much you can hike the tissue? The first thing that I look at the patient is I look at the defect and I say, open the mouth, and I look at the tuberosity. The tuberosity is the Angus beef for me. If there is no Angus beef, then I'm going to McDonald's, because I don't have tissue. So we suture the tissue, but this is not simple. It's appealing, it's attractive, but the beauty is that you can increase and have thicker interproximal tissue that really allows you to go in a totally different perspective of what we have been able to do among implant dentistry. This is the one that beats everybody, because here you can increase your thickness, and basically the idea is to go to the final abutment. When I hear about one abutment one time, I don't think it makes a difference. I have cases where I show X-ray, radiographic X-ray. Obviously, I can. Today, there are so many variables on what we do that you can always pick up a case to show something that is against or in favor of. But to tell you the truth, for me, delivering the final abutment is more easier for me as far as the rolling and outcoming of my marketing or my delivery of the case. Sometimes I haven't had the chance to have a previous zirconia abutment, and I still have the same results. So I don't think one abutment one time is as crucial if you do soft tissue grafting. So if you do soft tissue grafting, you can get away for a lot of the trauma you create in your prosthetic phases. And if you don't have a connective tissue graft, I think is an issue that you should go one abutment one time, because that tissue has not been increased, the phenotype has not been increased, and you will have a lot of problems. And I agree with what the literature says. The healing abutment, you don't realize how surgically it can affect the final outcome. If you have a tuberosity in a central incisor, it's a totally different approach from what you have learned in the prosthetic field. I'm mainly a prosthodontic mindset, even though I do everything myself and I'm a technician. But the distance and the space between the implant and the interproximal tissue is crucial to really be able, for me, to create tissue. I want to go back. In order to build in the buccal, palatal is crucial. I never do rotating flaps. I think it's the worst that you can do. The bigger the defect in the palate, the less you will be able to create something on the buccal, and it will be really unstable. So you will end up with pink composite or CS, whatever, Photoshop. So the idea is that's why I don't do too many one abutment one time on delayed approaches, because I want to grow the tissue first and then push it to my will as far as where I want to have my emergence profile based on a diagnostic wax-up. You need to understand that the more tissue you have, the less you have to push it. And then the more you can go into what Eric says about concave profile, because you have a thicker tissue where you need it the most, in the bottom at the interface between your abutment and your implant. So basically, allowing mechanically the biggest problems that we face at the interface when we restore implants is that the interfaces are way too big for what we do. Okay? So the smaller the interface is, the easier is to create the transitions, but you have to train in a different totally way that you have been trained, maybe. You can see this, the defect is the same case. We place a huge baby, really big Angus beef of 8 millimeters to that defect. This is a case that this was one of the first. So the paradigm shift goes to a smaller healing abutment because we didn't increase the bone. So it's a 3.5 usually healing implant. I can condense it. For me, novel active is novel addictive, you know. It's a lot of things that I can do with that implant. And then we place a small healing abutment to really allow minimum space from the prosthetic phase into my surgical manipulation. And then we push. The carving of the stone, the pushing is done by carving of the stone. And the carving should be done by the surgeon or the prosthodontist who knows the origin of the connective tissue graft. If the origin is from the tuberosity, push it. If it blenches and is white as my shirt, don't even be, don't dare. Don't be scared. It will never resolve. Okay? So we place the final abutment because it's way easier, obviously. The metal connection for me is essential. It will come out hopefully this year. And basically, you need to push that tissue. Connection in zirconia, you will break it because you have to create so much pressure. Obviously, the patient is under anesthesia. Okay, it hurts. You create an edema. Okay, but this is what it looks like a few months down the road. Initial 3 months, 5 years down the road. I have videos of all of this, but I don't have time to really show you. But you can see the creeping effect of the tissue. This is something normal in all the cases you're going to graft with tuberosity as a donor site. So the soft tissue, the density of the tissue is the one that is going to provide the height, the maintenance of that volume. So this is maybe the secret is to take that tissue and the retromolar pad is a great tissue too. Some people have, some people don't. You should know that the patient that has a really thin phenotype in the palate, it has it on the tuberosity too. Something that we do a lot is we extract wisdom teeth for free to have a great donor site, and we nourish it for 6 months and wait until we're going to place my implant. And when I place my implant, I take the tissue from the tuberosity. Okay? So I always treasured my connective tissue from tuberosity to place it when I place my implant. Okay? So this is what we are talking about. It's simple wedge technique where you take all that green part and you put it in front. So actually, when you have 2 implants together, this is even more difficult. Why? Because if you imagine having 2 normal healing abutments, not even in 1,000 million times you will have a nice result. Okay? So we place and we do 1 connective tissue graft, but sometimes I do twice because maybe the quality or the quantity that I want to get from the patient is not enough. You need to understand that a lot of patients that I get into my practice are desperate to have a final nice outcome. Okay? And people tell me, hey, are the patients willing to go through connective tissue graft? Well, you have to understand something. The morbidity of this procedure is way less than taking tissue from the palate and way less than doing bone surgery. So this is how to extract both central incisor. This is the second reevaluation after 3 months of this surgery. And what we did was to do another connective tissue to hike up the tissue and create more volume. And obviously, this only can be done if mechanically, prosthetically, the prosthetic part of my future is allowing me to place that tissue around. If not, it will necrose, it will expose, it will explode, and it will fail. The rest is pushing tissues. It's no incisions, no nothing. And at the beginning, you will see, I should have done more tissue. It won't look nice. But leave, this is always the same feeling. We take an impression, this is the original, where we started. We did the root canals, didn't work. At the end, we had to do bone graft, extract both central incisors because they failed. This is 4 years down the road, and I will show you a video just to show you that I don't have anything to hide or prove to anybody. It's just something that you should be thinking about it, having something as an armamentarium, another armamentarium as far as when you face your cases. Obviously, the papilla in between the implants will never be the same height as the interproximals, but 3 years is where you see the problems, if they are ever coming, and I think is really acceptable coming from maybe the most difficult area in implant dentistry. So don't get me wrong. Doesn't mean that I do bone graft. I still do bone graft, but I don't over contour as I was taught. I only do bone graft in order to place my 3.5 implant. I don't need more. What I need is tissue. If you overbuild the bone, you won't have space for your soft tissue, and then you will have a problem. Because if you have too much bone and you don't have space for soft tissue, then you are stuck. So this is the first on the top, in the bottom. This allows you to have a really primary closure. This is the pressure that you make to the tissue. So you need the tissue. The tissue is the issue. At the end of everything, I can show you, I can be really provocative and show you that the buccal bone doesn't really help you as much as you think it does. For me, interproximal bone and the stability of the implant is the one that really is going to create the difference. So we have plenty of, this is the temporary healing abutment. This helps you, especially on congenitally missing teeth where the teeth are spinning. They destroyed what you have done surgically. It's a nightmare because you have to go after your orthodontist. And basically, you see the different stages. You will tell me, he's loading the provisional. Well, we do that if we have a primary stability. Then we go to the final abutment. We did a little bit of gingivectomy on the central incisor, but those are on and on cases. This is what really allows you to combine connective tissue in the subprosthetic aspect to the top one. And basically, in order to place that healing abutment, then you are going to the next level, that is already prosthetically placing your implant, because you have the carrier, a carrier that already helps you as far as when you are placing the implant to have an idea what is 3 millimeter, 4 millimeter, how much tissue I need to hike, what type of design I have to do. You are placing the implant and you are already seeing what is the head based on your defect, based on how much you want to increase, based on the occlusion. So you are already driven your implant placement with your abutment. Usually in those cases, I place the healing abutment outside of the mouth, so it's easier. So you can, if you want to increase the space for your crown, your provisional crown, you can increase the space to have a more resistant provisional. The provisionals are not glued into this. Basically, they are glued to the adjacent teeth, and there they are resting. Okay? The idea is to have a stability of your provisional under function. So, and then you suture the connective tissue, and then in a second layer, you suture the provisional, and you do the final provisional. So allow me 5 minutes, and I show this case, and then with that case, we'll have a wrap-up, put all together. This is a 3-year case. It's the same case that I started in my presentation. And basically, no buccal flap. So a lot of thinking has to go through in order to decide what do I do, how I'm going to manage, high lip line, dentist, a lot of pressure. She had all variety of the treatment planning, but basically what we did was this treatment. She had a nice palatal bone. I decided to just, this is, by the way, Stimmelmeyer technique, having a pouch with some extensions to have less necrosis, and then we'll go and show the technique, nothing really, something easy, ridge lapped in the bottom. You see 3 months after this surgery, you can see the result. The same tooth usually is the best provisional because it's easy to bond to adjacent teeth. And then having this prosthetic face, what it does to this tooth, it provides way more stability. I hate people that come to my office, hey, the tooth is loose. Especially we use that when you have big diastemas, teeth that are really big. So the load is on the composite, and usually they crack. And so let me show you with this case the videos, okay? Not only the surgical phase, but the prosthetic phase, because some of you will have, well, what about what he does it? How does it do prosthetically to come up to that result? So for time purposes, you'll have 3 videos running at the same time. Here is the flap design. It's a little bit more buccal than crestal, never palatal if you want to increase height. And then here you will place the implant with a slim temporary abutment, and here the suturing using the 2 layers. So they are all at the same time, okay? So it's going chronologically time in this direction. Everything is partial thickness flap. We never expose the bone, and I want you to pay attention on the thickness of the tissue that is on the crest. This could allow you periodontally to really play a lot vertically at the crest, at this area. But there is something that I don't do too much as I used to, because I see that this provides a thicker tissue towards the palate. And then I can embrace and have a better response on the buccal. So you need to tailor where you need the most. A really simple incision also can allow you to go underneath the healing abutment. So basically the experience becomes about how much volume you need to know. I use Endogain quite a bit. I see a difference using Endogain as far as the healing. And then we are just rebonding, relying the same tooth and bonding to the adjacent teeth. And this is the way that she finishes, okay? So this is 3 millimeters on the buccal plus 1.5. It means you have already a really nice pontic, because for me, implants are like pontics. They are even easier to restore than pontics, you know. I have less work to do. And basically, I anesthetize and jump to a narrow healing abutment, a narrow impression coping. Have to anesthetize. Usually I give anti-inflammatories, ibuprofen. And we jump, coming from a diagnostic wax-up, I want to place the crown. So this is going in 24 hours. I can have a final abutment, and we place the final abutment. Here is the impression. You can see all the volume. Here you can see the volume that we have increased. The higher the volume, the better, but usually it's difficult. But the density is the one that favors the creeping effect of the tissue, because the tissue follows the emergence profile. The cleaning, we follow. The first time I use glutaraldehyde, the rest of the times you have to check. I always use saline water. We learned that from Eric really nicely, and you can see the volumes, and you can see how we make the pressure, no incisions, no cuts, okay? Prosthetically driven only by pressure, okay? So this is what it looks like where we started, the day of the extraction, what it looks like, the day of the implant placement, what it looks like, and then The prosthetic phase, where we clean it before placing it in the mouth, and obviously we clean it thoroughly, and then we try it. And before the trying, I always take out my final abutment. Why? To check for this. Cement remanent excesses, and then we usually cement with 2 cords, one in the buccal, one in the palatal. I want you to pay attention. All my cases, I do a CT scan. Today the radiation is minimum. But I want you to pay attention. No bone on the buccal. I can tell you I have implants with no bone at all, and beautiful aesthetics. So interproximal and implant stability and grafting is maybe, for me today, the most important issue. I can show you other things, but you need to see this presentation in order to understand other things that we do today that we thought maybe that those cases are impossible to treat. 3 years down the road, this is the creeping effect of the tissue. I haven't done anything. I say, do you want me? Can I cut it? No, Iñaki, leave it that way. I'm happy with it. So thank you for your nice attention, and thank you very much.